endocrine sufficiency, the malabsorption does not occur until the secretions are decreased by about 90%. Causes, again, I mentioned pancreatitis, but also cystic fibrosis, pancreatic resection, pancreatic cancer can present with this, and there's a number of tumors that can do this as well, such as the somatostatinoma. Diagnosis, stool studies, you'll see fat in the stool. You can certainly do a 3-day or 72-hour fecal fat collection, but you can also get an idea by just sending off a qualitative fecal fat just from even just a swab in the clinic. These patients will also have a decrease in fat-soluble vitamins, and this type of diarrhea may be helped with pancreatic enzyme supplementation. With bacterial overgrowth, as I said, you get a deconjugation of bile salts. You will get secondary damage to the small bowel mucosa, and you will get actually the overgrowth, the bacteria absorb B12, so the patient may be B12 deficient in patients presenting with bacterial overgrowth. Diabetes is a big cause, but also small bowel diverticula and post-surgical strictures. So patients with Crohn's disease who have a stricture of the small bowel, their presentation may be complicated also by bacterial overgrowth. Many of these patients will also complain of a lot of gas, very foul-smelling gas, and a lot of abdominal distension. Diagnosis, you can do a breath test to look for bacterial overgrowth. Small bowel x-rays may help define an anatomic lesion that's causing that. You can culture the fluid from the duodenum, but really probably the best if you're going to test is going to be a hydrogen breath test for bacterial overgrowth, or you could do an empiric trial of an appropriate antibiotic. All right, secretory diarrhea. These patients have a stimulated secretion of intestinal cells. These patients typically will have, this will be a large volume diarrhea. They have large elevated stool volumes. They may have hypokalemia. And if you're trying to differentiate between an osmotic and a secretory diarrhea, if you fast the patient, secretory diarrhea continues despite fasting, and osmotic diarrhea usually goes away with fasting. These, as I said, toxins would be the big thing. Cholera, C. diff will do this. E. coli, O157H7, Shigella will do this. These entities also will cause an inflammatory diarrhea, but a component of their toxin production leads to secretory diarrhea. And then there are a number of endocrine tumors that will cause increased secretion from the bowel, including excess VIP secretion, gastrin with ZE, and carcinoid. Villus adenomas are these very large villus polyps. They secrete a lot of fluid from their surface. Inflammatory products may also cause increased secretion. All right. So you got those really quickly, those 3 types of diarrhea. So C. diff. C. diff is exceedingly important, and we'll talk about it a little bit here, but if you come to Grand Rounds on June 23rd, we're going to talk about an hour about C. diff. You'll get more C. diff than you'll ever want to ever know. Anyway, it usually colonizes the intestinal tract after the normal gut flora has been altered. It's one of the most common healthcare infections, significant cause of morbidity and mortality among elderly, and these spores are amazingly resistant. You need to wash with soap and water to not pass them on, and we are entering a phase that hospitals will probably not be paid for a second admission for somebody who gets hospital-acquired C. diff infection. So there is up to a 50% carriage rate in hospitalized in patients. Patients will present with a watery diarrhea. They may be exceedingly ill with the toxic megacolon. These are the patients that may die from C. diff, or they may be an asymptomatic character. Cramping, low-grade fever, leukocytosis. Look for C. diff toxin in the stool. And actually, there's a very interesting algorithm that our lab uses for testing, looking for different components of the C. diff to give the highest yield on a positive test for the C. diff. And endoscopically, you may be just a little bit of redness, or you may get these pseudomembranes. If they show you an endoscopic picture like this is probably one of the more classic endoscopic pictures they could show you. And in the right setting, this would be pathognomonic for a Clostridium difficile. So you want to stop the offending antibiotic. Typically, for patients that are less ill, we'll use oral metronidazole, oral vancomycin. You can't use IV vanc because it doesn't get to the gut. You can use IV metronidazole. Sometimes we'll use a combination. And there was an antibiotic that was just approved, I guess, a week ago for C. diff called fidaxomicin, or I can't pronounce it right, but it looks like you're fixing stuff with it. But well, you'll see that again on the 23rd. You can get recurrent disease in up to 25%, and we have a whole number of strategies for treating recurrent C. diff, including tapering off antibiotics, pulse antibiotics, and stool transplantation. All right. So, anyway, small bowel. This patient is a 44-year-old who presents with abdominal pain and anemia. During the workup, a small bowel biopsy was performed. A PAS stain was done, and the stain revealed foamy PAS-positive macrophages. What is this patient's diagnosis? 1, Whipple's disease. 2, chronic pancreatitis. Number 3, Zollinger-Ellison syndrome. Number 4, celiac, or number 5, eosinophilic gastroenteritis. Whipple's? Everybody raise your hand. This leads us to the next. So chronic pancreatitis, the small bowel would not look abnormal. The acid can cause damage, and you can get some flattening of the villi. Celiac, you will get flattening of the villi and absence of villi, plus an increase in lymphocytes. And eosinophilic gastroenteritis, the bowel is just loaded with eosinophils. It's very classic. So there are certain things in GI that it's really helpful. These are histologic patterns that are so classic that it's worthwhile knowing these, because you may be given a situation where the patient had the following presentation, was biopsied, and the biopsy showed this, and now what do you do? That would be very fair. And the diseases that would be very easy from the GI standpoint would be things like Whipple's disease, celiac, GIardia, collagenous colitis, CMV, cryptosporidiosis, and eosinophilic gastroenteritis. And I've got some samples of some of these. So, what is this? High-powered PAS stain, and this is Whipple's disease. Whipple's causes these foamy PAS-positive macrophages, and it's fairly classic. Now, how many cases of Whipple's have I ever seen? And I've been doing this for a long time, over 25 years. I've seen one patient with Whipple's disease. And it's typically going to be it's more common in elderly men, and they may have a little bit of dementia, and they may have diarrhea. But if you don't think about it and look for it, you're not going to find it. And this is a bacterial disease, and it's treatable with antibiotics. And it's just a classic finding. All right. So what's abnormal here? All right, first of all, what is this? It's a lining of some sort. Now, typically you would be told a small bowel biopsy was taken with the following findings. So this is small bowel, and the abnormality here are these little round things on the surface. Okay, so when you look at the small bowel, you want to do a couple of things. You want to look for inflammation in the lining, so you're looking for eosinophils, you're looking for foamy macrophages. And then you want to look at the lining of there. And the kinds of things that you might see on the lining are things that adhere to the lining, and the common things that would be GIardia and cryptosporidiosis would adhere to the lining. So don't panic when you see a biopsy. Look at the two components of it and try to figure out where something's not right. And this is actually cryptosporidiosis, these little round things on the surface. All right, so look at this. I'm telling you that this is not a small bowel biopsy. This is a colonic biopsy. So you want to look in a couple of places. You want to look here at the lining. You want to look underneath the lining. and the lamina propria, and what's not right here? Anybody? Okay, what's not right here is that these glands should really be up against the lining here. And this is not, they would probably give you two stains for this. This is an H&E stain, but you see this pink stuff underneath the lining? That's collagen, and this is collagenous colitis. Hopefully they would give you a collagen-specific stain that would be like bright green. So again, you want to look underneath the lining, and if there's a band of pink underneath the lining, the typical scenario for this kind of person would be a middle-aged female who everybody thinks has irritable bowel syndrome because they have diarrhea, cramping, abdominal pain. You look at their colon, the colon looks totally normal. You get this biopsy back, and you get collagenous colitis. And then you would be asked, what are you going to use to treat it? Anybody? Budesonide, Entocort. So collagenous colitis, middle-aged female, IBS-type symptoms, colon looks normal, you get this biopsy, and Entocort is typically what we use to treat collagenous colitis. So just to, not a board type thing, but if you're out in practice taking care of a patient, you either are doing flex sigs in the office or you send a patient for a sigmoidoscopy. Before you can really label a person as having irritable bowel syndrome and they presented with a diarrheal complaint, you may need to make absolutely certain a biopsy's been done. If a biopsy hasn't been done, they need to get sent for a biopsy. All right. What's this? GIardia. I mean, this is a nice little guy looking at you here. So it looks like falling leaves. And when you do, you could be given a smear like that for GIardia. But also, if you look at if they give you a biopsy, a small bowel biopsy, and I don't think I have that. No, I don't. So with the small bowel biopsy, you would look at the surface, and instead of those nice little round things we saw with the cryptosporidiosis, you'd actually see stuff that looks like the falling leaves on the surface and in the lumen of the bowel. All right. So GIardia, it's very common, contaminated water, fecal oral transmission, incubation is about 1 to 4 weeks. Patients get explosive watery diarrhea, cramps, nausea, bloating. Bloating is a really big thing. So if you have a patient that has chronic diarrhea and is having a lot of bloating and flatulence, sure, you need to think of a malabsorptive diarrhea, but if you're thinking about a parasitic cause, GIardia is there, and it's because you're getting malabsorption. It adheres to the lining of the duodenum, and you get malabsorption, and so you will get bloating and flatulence. Relapses are common. We typically treat 5 to 7 days with metronidazole. All right. Now, celiac disease, again, it's a gluten-sensitive enteropathy. Incidence is 1 in 133 people in the U.S. And if you have a first-degree relative with celiac, that increases to 1 in 22. You see it more commonly in Down syndrome and Turner syndrome, and they have, if you do testing and you're missing HLA-DQ2 or HLA-DQ8, or if you have celiac disease, almost 100% of people will have HLA-DQ2 or HLA-DQ8. So if you don't have those, your negative predictive value is exceedingly high. It's close to 100%. The serologic testing, you can do either the anti-endomysial antibody or the anti-tissue transplant glutaminase antibody. These are very sensitive. This is you may get thrown anti-gliadin antibody. That's not sensitive or specific. So it's really the anti-endomysial or the anti-tissue transglutaminase. Now the problem is with these is that both of these are IgA antibodies. All right. So if you have a patient, if you're doing this, you probably should check an IgA level too, because if you really suspect celiac disease and they're IgA deficient, you are not going to get a positive antibody because these are IgA antibodies that are tested. You can send it out for an IgG. Mayo does that, or the gold standard really would be the biopsy as well. And this you can refer back to, but basically it has to do with the absorption of gliadin. It's presented in conjugation with antigen-presenting cells to sensitize T cells, and then you get changes in the tissue transglutaminase deaminase, the gliadin peptide.